Welcome back to Bread and Butter Primary Care. I'm Dr. Stokes, and today's video we're going to be talking about depression, important history elements. So we already talked a little bit about what depression is and why we care, and so we're going to start with history and kind of go video by video on how to evaluate, diagnose, and manage someone who may be having clinical depression. So history elements for depression. I like to approach getting the history for a patient with mental health or depression issues in two ways. One is actually on intake, which usually the medical assistants or the nurse or other staff are able to do, which is a written out questionnaire that they can fill out. There's a few different questionnaires that are used. There's the Beck Depression Scale. The one that I use in my office is the PHQ-9. So I think it's the Personal Health Questionnaire 9. There's 9 questions. And so that is a questionnaire that they can go through, and then you can get a pretty good sense of where they're at with any sort of symptoms of depression. And then that you have that information before you even go into the room, and then we'll kind of talk about the history that I would usually get when I'm evaluating a patient with these difficulties or issues. So the PHQ-9 goes through the 9 cardinal symptoms of depression. So these are the things that are listed in the DSM criteria for clinical depression. And so going through those gives you a good sense of where a person is at. It's also a scoreable scale. So when you get done, it can give you a score and rate it mild, moderate to severe, which we'll talk more about when we talk about choosing types of treatment for clinical depression. So the 9 elements of the PHQ-9, we'll run through those. So anhedonia is one, which is lack of interest. So it's a lack of interest in things that used to be fun or that used to interest a person. So you oftentimes will ask, do you find that you don't enjoy things that you used to enjoy? So that's one. Depression, so feeling down or depressed. Frequent sadness is another element of the PHQ-9. Problem sleeping, so either sleeping too much or too little. Problems eating, also too much or too little. Having too little energy, feeling tired or fatigued all the time. Feeling that you're running so fast that people could notice, or the opposite, that you're going so slow that people would notice. Feeling hopeless about the future. Feeling bad about yourself, or that you've let others in your family down. And then the 9th one is suicidality, any thoughts of harming yourself. And people rate themselves on a scale of never, some days, most days, every day. And they answer those questions as far as how often those things happen in the last 2 weeks. And then you get a score that will kind of rate them out. And so oftentimes if someone is coming in with concerns of depression, and in a lot of offices, even universal screening is used, in which every patient fills that out before you see them. So you always have a sense going in whether or not this is an issue and whether it's not something you should address if you are able to do so. And so that I go in, already knowing that, hey, we already got this score on the PHQ-9, or they answered yes to these questions, and so I kind of have a sense of what's going on. And so as far as when I get in and it's time to gather the history from that patient, I tend to leave the HPI elements of depression as open as possible. So you do a lot of the same OPQRSTA questions that we talked about in the video about taking a general HPI. When did this start? Has it ever happened before? Is it getting worse? Things like that. Is there anything that brings it on? Anything that relieves it? And that information is good, but generally I like to just ask my patients who are having these symptoms, tell me about what it is that bothers you in how you feel. And then it's very open for them to describe. And as they sit and describe it, and then oftentimes they'll even go through those 9 things and they'll mention those types of things in their narrative that they have about that. And so oftentimes people will say, well, doctor, I'm here because I'm depressed. And then so I'll follow up and say, well, tell me about that. When you say you're depressed, what type of emotions are you having? What are you feeling? What goes on day to day that makes you feel that way? And then they'll say things like, oh, well, I feel like I just can't ever get anything done, that I'm too exhausted and tired, I don't care about anything, I couldn't care less if I do things. I don't enjoy my hobbies anymore. I cry all the time for no reason. Those types of things. And so then they kind of go into that, and then you kind of can just have a conversation about the symptoms that they're having. And so having had the PHQ-9 before you even go in, or the Beck Depression Inventory, whatever it is you want to use, really gives you the advantage to this idea that I've already got the nuts and bolts of like the elements I need to diagnose what's going on. And now the history can really be a conversation about how does this affect you? And that's also an important question to ask both for depression, anxiety, and mental health disorders, is how much do the things you're describing. So I'll ask the patient, tell me what is going on. What is it that you feel or experience? And when they finish, I'll say something to the effect of, how much do those things affect your life? Do they prevent you from going to work? Do they stop you from going to school? Do they stop you from spending time with family? Are there things you would like to do, but you don't do because of these emotions that you've just described to me? Because that's an important part of that diagnosis as well. Everyone has ups and downs. Everyone feels good sometimes. Everyone feels bad sometimes. But when the feeling bad is most of the time, and when it stops people from doing things that they would otherwise like to do, then obviously it's something that's causing a disruption in their life, and likely they could benefit from a variety of treatments that are available for that. And then a big part of history taking in mental health situations is suicidality. Sometimes it can be an uncomfortable conversation to have. It can be an uncomfortable question to ask, but I have found that the more you do it, the easier it is. And a lot of these patients who struggle with this, it's not weird to them that you're asking this question, because likely it's something that they have struggled with or that they have. And oftentimes there's even sometimes a sense of relief that it's okay to talk about it, and it's okay to mention it, and it's not, it's not like you're going to freak out or something. And so generally I try to approach it as nonchalantly, I guess would be a good term, as possible, and just saying, with these emotions that you've described, with the problems you've been having with your mood, have you ever felt like you'd be better off if you weren't here? Have you ever thought about hurting yourself? Have you ever thought about ending your life? And then oftentimes the answer will sometimes be like, well, yeah, the thought comes into my mind. And then, well, as the thoughts have come in, have you ever got to a point where you plan to do something, or that you attempted to do something? And they might say yes, they might say no, but it opens up that dialogue. And I try to have that conversation in a way in which there's no surprise, there's no shock on my face, there's no anything like that, because this is part of the pathology of depression and mental health, is this sense of hopelessness, which can lead to those types of thoughts. And so it's horrible to say that it's normal, because obviously those types of thoughts and tendencies aren't normal, and that's why they're at the doctor, and that's why we're going to talk about treating, because we want to get these people and these patients to a place where they're able to function just like we would with any other medical condition. And so it's good to have that conversation. It's a necessary conversation to have to make sure that the person feels safe. In the case that they answer, yes, I feel like that all the time, and actually, yes, I have a plan to do so. In fact, I'm planning to go do something right after we get done here. As you ask those questions, sometimes you might have those situations in which you can then talk to the patient and get them somewhere where they feel safe, and somewhere where they can get things to where they're safe and can be managed outpatient better, which we'll talk more about when we talk more about the treatment and of depression in further videos. So that's the general history idea when you're taking a history on a patient complaining of depression. Get a screener that you like that is comprehensive, like the PHQ-9 or some other inventory, so you have the nuts and bolts before you even go in, and then to have an open conversation with the patient about what they feel, how it affects their life, and then that can lead right into discussion about what can be done about it, which we'll talk about in future videos. I hope that's helpful, and have a great night.